So welcome you to the session. I wanted to quickly thank the International Hospital Federation for giving us space for discussing violence against healthcare in the World Hospital Congress, and also for the partnership that we have been developing with them in the past 10 years, which is quite significant and important to us at the International Committee of the Red Cross. So without further delay, I wanted to start my quick introduction to the topic. So, sorry. My name is Anna, and I work for the International Committee of the Red Cross. As you saw, I work with a very specific file of violence against healthcare. And I'm here to share with you some reflections that we've made with great partners about the topic. But then, what are we talking about really, right? What is violence against healthcare? So very quickly, violence against healthcare. It's a type of disruptive, negatively disruptive event that affects people or health facilities or health vehicles, or simply the circulation and access to healthcare. So I could give you several verbs to describe these types of events. We could be talking about physical violence, harassment, threats, abuses, looting, arsoning, shelling, bombing, you name it. We could have several names to describe it. But the idea is that we have a violent event, and this violent event has an immediate consequence and also a knock-on effect that we're going to try to cope with, right? To facilitate a little bit of how we look at this phenomenon, I try to describe it here in a spectrum that goes from violence that happens in a context that is very familiar to all of us, I guess, working in healthcare facilities, and that is usually related to tensions at the workplace, up to the point where we actually have problems of conduct of hostilities in war, where we actually have problems with military operations that violate some principles of respect to protection of the medical mission. In the first part of the spectrum here, which is what we see more commonly, we would have violent events related to stress, related to mistrust, or to ethical misconduct, for example. It's not very unlikely to see that, for example, when family members are not happy with a treatment that is provided to a patient, they become aggressive against the nurse or the doctors who treated the person. We also saw with the COVID response that several events were happening because of the questions that communities several times they had and that were unanswered or that were miscommunicated, that were politicized, and that turned into violence. And then moving a little bit further beyond, we have violence that is sometimes triggered by cultural practices or circulation of weapons. So we would have, in this example there, several ambulances, you can see them sort of parked. But the reality is that in Pakistan, they have this not very useful practice of transporting dead bodies in ambulances. And so usually when there's an ambulance passing by in a crowded avenue, they're not going to let the ambulance through because they don't know if the person inside is alive or dead. They would just assume, okay, maybe it's someone dead, I'm not going to let the ambulance pass. And this triggers several violent events against the ambulance drivers and the team, because people have, this cultural practice that is simply not helpful, Circulation of weapons is also a problem, and we see, for example, when we have complicated health responses, such as the Ebola one, and you have a place where weapons are freely circulating, you also have challenges to manage how violence is affecting the health services. Moving a little bit beyond that in the spectrum, we have violence that is triggered or directly connected to the insecurity of the area, of the region. So we would see problems related to criminality, to social disruption, or protests. This is an image of a very, very complex neighborhood in Rio de Janeiro, in Brazil, where military operations from the police are often impacting delivery of health services. But we also see here an image from the Black Lives Matter protest in the US, where also the operations carried out by the police to control the social unrest that was ongoing with the protests blocked, for example, first aiders from providing care during the protest. And then in the far end, of course, we have very, very problematic scenarios related to war and violations of international humanitarian law. And there we have, for example, direct targeting of hospitals, ambulances. We have persecution and torture of health workers, and we have direct blockages on delivery of care. So these are very complex scenarios with very devastating impact, but that's the reality that the International Committee of the Red Cross is constantly working with, right? So as we saw, we have different perpetrators of violence, so we cannot really talk about one single group that commits this type of violence. It might come from family members, it might come from peers, it might come from state authorities, it might come from parties of a conflict. We do reinforce that in conflict settings, in war, these are violations of international humanitarian law, and this is something that we should never forget. But in peaceful times, they're also obstructing a person's right to health. So this is also something that we shouldn't be forgetting. And of course, myself in the International Committee of the Red Cross, I would focus in the situations of conflict. But I wanted to share here today, and this is one of the big points of discussion, is that there are several organizations already stepping into this area and working with this problematic issue. And we have to address it in all of its dimensions, not just in one particular realm. So what does data tell us? So what's the magnitude of the problem? What can we say about it? So first of all, you will find several of these type of studies like I highlighted here. It's really not for you guys to read, but the idea is that these are two studies talking about prevalence of workplace violence. It's a very generic thing, so measures are very different from one study to the other. We don't have a very good definition to put forward. The samples are also usually very different, but you can see very, very high levels of prevalence. So on one side we see 97% of medical staff suffered verbal abuse. The other one saying that 80% of the health workers had experienced one or more types of violence. And then ourselves in the ICRC, we did a review, literature review with several studies that were discussing these different numbers. And this is just a generic distribution for us to have an idea of how different the levels of workplace violence, of physical violence were found. So the idea here is that instead of discussing workplace violence, we selected one construct, just physical violence, just that. And within the studies that were addressing just that, you see the distribution is very, very different. You have from almost no one suffering physical violence to studies where almost 40% of the interviewed health workers had suffered physical violence in the past year. And moving on, so the ICRC also looked at our own data. And between 2015 and 2017, we had identified 1,200 events of violence in 16 countries. But here what I wanted to show you is that there is a multitude of places where these events were noted. So in a healthcare facility, but also in a public space, in a checkpoint, in the vicinity of a healthcare facility. And these events, although we might feel like this is not a very big number, 1,000 events in 2 years, look at the numbers of dead people. We're talking about over 3,000 dead people in these events. So actually, these are extremely severe situations with a very deep impact that is very badly documented also. Because if we go back to that image that I showed you just now about those studies talking about workplace violence, there we don't know the impact. So we're still talking about the superficial description of the phenomena of asking someone, have you ever suffered verbal abuse or physical violence in the workplace? And when we start looking at the impact numbers are so severe and problematic that we might get scared about talking about it, right? So this is a very good overview of the year of the pandemic, 2020. So this excellent coalition of organizations, the Safeguarding Health in Conflict Coalition, they work with Insecurity Insight, one of their member NGOs, to develop this type of overview. So what you see here in red, I'm not sure if you can see the red because of the light, but it's the bottom part there, are events related to conflict, so incidents that they documented related to conflict and war. And the ones in green on top of it are events related to COVID. So for the year 2020, it was well documented, for example, that COVID had triggered further on the violence within healthcare settings and against health workers. But then now talking about this year, 2021, where is this happening? So we could, of course, look at the most typical emergency affected settings and say that, well, it happens in the Central African Republic or in Syria, Afghanistan, Haiti, Myanmar. But what I tell you, and these are all from this year, all of these images you're seeing are from these years, is that this is also happening in France, in Poland, in the UK, in India, in Chile, in Nigeria, in Canada, in the US, as we're going to hear in just a moment also. And these would be a global distribution of what we currently have available by Insecurity Insight with this global dashboard that they developed with the Berkeley School of Law. So indeed, it is a global problem. You know, we don't know how much it is affecting us yet. We don't have the right numbers. We know that it's underreported, we know that it's underdiagnosed, but it is a conversation we must have because it has a deep impact to the way that we deliver healthcare services, and this is why we decided to bring then together people that could be effective and powerful in changing this reality. So the International Committee of the Red Cross works with this partner organizations that you can see here, and of course the International Hospital Federation, the World Medical Association, WHO, they're all part of these discussions. We develop a series of events and guidance material, public campaigns, and this is all what we call the Healthcare in Danger initiative. So this is a global movement that we try to put people together to discuss and act on the reality of violence against healthcare. And with this in mind, we selected 3 very special partners to be together in this session and discuss and tell us actually what they've done to tackle the problem. So here today, the idea is really that we're not going to go into detail to talk about how many incidents there are and where. We're going to talk about action, what can be done and how it can be done. So I'm very proud to have here someone from South Africa, the director of the emergency service of the Cape Town Governorate, talking about how he handled violence against healthcare in an ambulance service under his responsibility. And then we're going to have the very dear Robin talking to us about the American Hospital Association experience on handling violence against healthcare. And finally, Paul from the International Association of Healthcare Security and Safety, telling us about concrete resources that are available for anyone who wants to work on the issue. So without further ado, I will leave the floor to Dr. Shaim De Vries. He's not here with us today, but he is in fact with us, he's online, but he left the intervention recorded, and it's a beautiful one. It's a very humane approach to the topic, and I'm glad to share that with you guys. So let's go to the video, and then we'll come back for Robin's live intervention.
Thank you to the organizers for inviting me to participate in this conference. I must say I do feel honored to be considered, although I do feel a little bit left out as a pre-hospital provider. I did not think I'd be presenting at a hospital conference. But I'm incredibly honored to share our story with you. So my name is Dr. Shaheen de Vries. I am the medical director for the Western Cape Emergency Medical Services in South Africa. And so I do have a couple of disclaimers right up front. The first to say, this is my story, it's our context, and I don't assume it to be the same for others. And it's really just our journey that we're sharing, and hopefully it's valuable. And the second thing, I guess, is there's not a data-rich presentation here. I'm really just using a process philosophy stance on my presentation and pragmatic view. So bear with me as we go through this. The format of the presentation will take the following shape. We'll deal a little bit about a context. We'll get into mechanism and outcome, a little bit about our interventions and our learning journey, and if there's time, some questions at the end. So the context that we are embedded in is one of, I guess, pertinent to the topic of this particular conference, and that's around staff attacks, and in particular, ambulance attacks. The article on the left is from a local newspaper, which featured very prominently when the spate of attacks had reached a peak. The article on the right is Pumzile Dlamini, who tragically lost her life about a month ago while on duty. She was gunned down. Her partner is currently still critically ill in hospital. And it was a vivid reminder just at what's at stake. And so for the next part, I think the context is best described by the staff themselves. So I offer the following recording. Thank you.
The fear never goes away. You always have that fear. We all feel, you come to a point where you don't want to come to work anymore. At the end of the day, we're putting our lives at risk for somebody that we don't even know.
My partner was stabbed with a bottleneck, and they held the bottleneck to her throat. And at the same time, I'm trying to defend myself against these guys that's also stabbing against wanting to stab me. And at one point I shouted, I said, you know what, just leave her alone and come get me. It was only a day after that I realized that things could have gotten so worse. I could have paid with my life. And these are the things that we need to deal with. You know, it's scenes like this that makes one, I mean, we two, and these are people that knows the area. So you don't know who's innocent bystanders or who's just people that's trying to take a chance.
Always make sure that everything is locked.
Hello, ambulance.
Hy moet sy pille gereeld gebruik. Toe die pille vergiet gaan hy dop en toe kry nou weer die aanvalle.
Does your family worry about you?
All the time. After, especially after incidents, when my mother, she reads in the papers and stuff, she will call me, you must be safe out there. My husband will phone me. All of them are worried. That's why I don't even like to phone later than 11. I don't phone home because they will think maybe something is wrong, something has happened. For some reason, you just come back. And after all this incidents, you just have to come back and make the most of it, you see? Because this is something that I love. I like to be here.
Sometimes we hear these crimes going sporadically all over the news. We hear EMS staff being attacked. And then at the end of the day, when we come on duty, we hear it's always somewhere in another district, in another division. And then it happens to you. We don't expect that. But yet again, something needs to be done. Because an attack on one crew is one too many.
So, yeah, I mean, as a service, the idea of keeping our staff safe in that context is incredibly daunting. This year is a breakdown of the attacks that we had experienced over about a 3-year period, and broken down by days of the week. And I guess there's a pattern there if you want to look and see. It's not a pattern unique to the ambulance service, unfortunately. And yeah, we again broke the attacks down by time of day. And largely, no surprise, most of our attacks happen between 9 in the evening and 3 in the morning. And I guess that's what it says, is that this isn't, an idea of us being attacked because we happen to be health workers. This is because we are being attacked because we have those characteristics that make us vulnerable to, or anyone vulnerable to being attacked in these communities. We are unarmed, we are usually alone, and we're usually distracted, busy tending to our patients. And so that makes us easy targets for those who are on the prowl. We've also looked at the attacks by assault category, and as you can see here, the attacks themselves are not surprising. We've got physical assaults, verbal abuse, threatened by weapons, stoning, staff robbed. The gang violence is an outlier. We do have a very active gang community. And so that's not surprising. In 2015, there was particularly gang warfare and turf warfare at the time. And then obviously hijacking. The other thing to say is, since we started recording these, this is old data, but since we started recording these, the threshold at which staff were reporting also lowered. And so there's no doubt that verbal abuse is probably the number one category, and as is physical assault, being shoved or pushed or held. So I thought I'd present a little bit of the data, but this isn't only about data. So I'd like to get into a little bit about the mechanism and the outcome. So at the moment, if you call for an ambulance, we determine whether or not your call, your emergency is located in a red zone. So what is a red zone? But essentially, red zones are those parts of the city where staff have been attacked in the past, or there's a high likelihood of being attacked. And what happens is, once a red zone is declared, we are unable to respond to that suburb or community without a police escort being present. Now, this has significant consequences for both the citizens and the service. Police, like ourselves, are severely constrained service. So you can just imagine linking two heavily constrained services and making them contingent on one another, what that does for response times to emergencies. So the creation of red zones has been one of the things we did, and it's an attempt to control something which really isn't controllable. If we look at this slide, on the left are those suburbs in Cape Town that are where we have the highest incidence of gunshots. Those suburbs are also, no surprise, the suburbs where that are red zones. And so what that shows is that the violence is not just violence directed at us, it's violence in those communities. Those who are vulnerable are targeted. And when we enter into those communities and we demonstrate our vulnerability, we become fair game. The graph on the right is our performance over time. So we get measured from the time you make the call until the time we arrive at your door. We have a target of 15 minutes. And so for most of our the first half of, I guess, this last decade, we've been hovering in and around 60%, 70%. In 2016, we declared red zones. And what you find is a precipitous drop in our performance. Yes, there's been increasing work, but the drop was not explainable only in the increase in volume. And now what we are doing, we are seeing performance levels at 18%. We haven't seen that in 15 years. So what does that mean? Well, maybe just a little bit about red zones and what that means for the suburbs. And so let me just take it one step back. So what usually happens is, if I live in a suburb that is not a red zone, I don't have to worry about gangs fighting in my streets. I don't have to worry about being attacked at night. I live in a leafy suburb and I'm safe. Surely, if I have an emergency and I call for an ambulance, I can expect the ambulance to respond fairly quickly because they don't need to wait for an escort. The problem is that we are a tightly coupled system, a complex system, which means that a common pool resource such as ambulances are delayed everywhere, whether you live in a leafy suburb or whether you live in the heart of a gangland. And so what has happened to our performance is that although we can stratify a risk per suburb, the whole city suffers. And so what it presents with us is a particular issue around staff attacks and I guess violence, is that violence is not a nominal threat. So here we have a breakdown over the last 6 years of the number of incidents of staff attacks. In 2014, we see 26. 2015, we had the large number of gang activity, 65. We peaked in 2017 at 87. And in 2019, through a host of interventions, we may conclude that our interventions worked in 16, and the number was that low. The problem is it matters not what the number is, because the threat is an existential threat. It is a threat. It is the risk of being attacked, as we saw in the video. It doesn't matter that I'm not the one being attacked. It doesn't. What materially changes is my decision to come to work. The things that I consider when I come to work, the things I consider when I respond to a call, the things I consider when I pull into a driveway or when I respond to a neighborhood. And it's this threat and this risk that is the challenge for managers and for a management team to manage, and yeah, it's virtually impossible. I cannot prevent staff from being attacked ever. So what do we do? What we've learned is, number one, is the importance of leadership. The lady in the center is my head of people management, HR. And this picture was a combined protest outside of a court where perpetrators or alleged perpetrators were being trialed after they'd attacked one of our crews. The lady to the right of her is our wellness coordinator for the province, and to the left is my city manager. And so I think what it forced us to do is question our own leadership and not just our presence, but what we stand for, what our actions. This isn't something to manage behind a desk or via an email. This requires presence, embodied presence. The second issue is that of support. This, on the same day, this is my HR team, who basically administrators sitting behind desks, who felt sufficiently moved to show their presence and show their support. And what this has shown us is that this isn't just about the front line being protected. It's about every one of us as citizens being able to make a stand for what is our constitutional right. The third and most crucial point is that of engagement. And it's probably the one we do the worst at. As a pre-hospital service, what we have to do is we have to engage with the communities, and we don't normally do that very well. And so we've had to learn and develop new skill sets and how to speak, not just to communities, but with communities, and how to problem solve the issue of safety, not just our safety, but their safety as well. And then there's the work around shifting the narrative. Both these are creative pieces done by filmmakers around the topic of ambulance attacks. And whilst they are beautiful pieces on their own, it's the conversations that they allow and enable that was quite material and that was quite crucial to the ongoing dialogue. And that's not just shifting the narrative within the community, but also shifting the narrative within us, shifting from being victims to being empowered, to able to make decisions to go to work, decisions to respond, decisions to remain at home. And I think that the last thing to say is that what we've encountered is something which is an existential threat, such as safety, has actually become one way in which we were able to find new meaning, able to find new ways of working, find each other, and different ways of speaking and being as an organization. And really, things brought to mind that Nasser Terib's book around anti-fragile. And I think that's the path that we are on at the moment. So in closing, the issue of healthcare workers is not a nominal threat. It doesn't matter how many attacks happens. One attack is one too many. It's an existential crisis, and one that we as a collective health platform have to address. Second issue, this is a wicked problem. There is no control here. The control is an illusion, and therefore requires very different ways of approaching and managing the situation. Leadership is crucial, but it's distributed leadership. It's a new idea and new understanding of leadership. And finally, we need to find ways to shift the narrative, not just about our communities and safety, but also about who we are as a profession. And so that brings my presentation to a close. I would like to thank you for affording me the opportunity and for allowing me to run a little bit over time. Thank you.
Sorry about that. Okay, so thank you to Dr. De Vries. Indeed, I just wanted to highlight, apart from his excellent final remarks, the effort of documenting incidents in his service, how well he has been doing that for years, and very, very accurately pointing out how complex it is to manage the problem, because it's not just putting in place a certain type, a number of measures, because that might actually impact your efficiency in responding. So when he talks about the delay of ambulances, once you couple the ambulance service with the police escort, is a concrete problem that falls back to health managers and health decision makers. So very interesting and very also inspiring reflection. Now I will give the floor to Robin Bagley, who is here representing today the American Hospital Association, and will then tell us how the American Hospital Association has been discussing and concretely tackling the problem in their work. Thank you.
Thank you, Anna. And welcome to everyone. Thank you to our attendees. I know it's getting late in the day, and I appreciate you being here. As Anna mentioned, my name is Robin Begley, and I'm the Senior Vice President and Chief Nursing Officer for the American Hospital Association, and also CEO for our affiliate, the American Organization for Nursing Leadership. And we've been involved in this work for a number of years. And part of my role at the AHA is to lead the workforce efforts, and included in that is the Hospital Against Violence initiative. We also call that HAV. So today, I'd like to share more about our violence prevention effort and the development of a comprehensive framework to support our members in fostering a culture of safety. So more about the American Hospital Association's Hospital Against Violence, or HAV initiative. It was the AHA Board of Trustees probably back in around 2016 that recognized the growing threat of violence, particularly in our hospitals. And with the support of the board, AHA created the Hospital Against Violence initiative to include both workplace and community violence. So we continue to engage with our members across the country to understand the challenges they face and how HAV can support with educational offerings, tools, partnerships, supporting research in this area. And I think that, as we saw with our first speaker, it's very complex. And we have inner city violence, we have hospitals in our rural areas. No one is immune, unfortunately, and the issues can be different. But also there can be some very common themes. So, here is just a list on the screen of our HAV advisory board. The advisory group includes C-suite level leaders from all over our country who provide input and strategic direction for our violence prevention efforts. And this group, and I'm one of the staff assigned to this group, obviously. We met all during COVID, thank goodness for Zoom technology, and it was clear from the very beginning that we needed to protect our workforce and create safety in our healthcare settings, even more importantly now during COVID, which was definitely an accelerant to some of the violence we were seeing. We also recognize that violence in our communities affects our workforce and can impact patient care. And perhaps you can see from the names on our list that, we had some clinicians, physicians, nursing leaders. We also had administrators from all over our country. And I will tell you, to a person, every single one is extremely passionate about this work. So today, I'll be sharing more about the process and learnings that came from developing our comprehensive violence prevention framework for health and security leaders. And as a reminder, the framework, as well as the document that we have recently produced and disseminated, is available both through the conference app, but also through our website. And at the end of the presentation, you'll see our website address on the screen. So a framework that addresses the many types of violence we witness in healthcare settings. This is a framework that also aims to create or to make better the environments that we have already dedicated to quality patient care. So to ensure a comprehensive and innovative framework, we convened discussions with a variety of stakeholders and collaborators. And the one thing that became crystal clear immediately is that leadership needed to be front and center. Leadership is necessary to activate each pillar: culture of safety, mitigating risk, violence intervention, and trauma support. There's a whole body of work really underneath and supporting each of these pillars, and we are continuously learning of new resources and adding them to our toolkit. And I just want to note that our team started with only 3 pillars, and it was our advisory group that reviewed and really challenged us and said that we needed to include trauma support, because it is not just about the violent incident, but how it affects the individual and their communities. So about the 4 pillars. The culture of safety is about prioritizing physical and psychological safety, both equally as important for our workforce, patients, and families. Number 2 pillar is mitigating risk, and this is about continuous assessment of potential risks and vulnerabilities, working with our multidisciplinary teams charged with improving the environment. Our 3rd pillar is violence intervention, and that's all about working with the community and our patients to prevent ongoing or future violence. There is growing evidence and support for hospital-based violence intervention programs from our members and from lawmakers. You know, for a while there, this was something that we didn't really want to talk about. And it was, kind of, provided or promoted a stigma. But we know that this is the reality in healthcare today all over, and unfortunately, nobody is immune. These programs place violence interrupters in the care delivery for victims of gun violence, reducing future acts of violence and improve case management for the long-term healthcare needs of these patients. Here's another example of how our members inform this framework. Initially, we called it violence prevention, but at their urging, it became violence intervention. While we still focus on preventing violence, we also know that there is, it's pretty impossible to completely eliminate it. So we wanted to create awareness of what one does once violence occurs and what we can do to prevent future violence. And we focus on the specific roles of hospitals and health systems. And number 4, the pillar that we added, trauma support, is about enabling pathways for understanding trauma, both physical and non-physical. We know that both our workforce and our patients are dealing with compounding traumas affecting overall health. Leaders can help by providing space and time to recover, build resiliency, and prevent re-traumatization. So where do leaders begin? That's really a dilemma. The framework highlights 3 areas: education and training, data collection, and keeping all levels of the organization accountable. As I mentioned, it's complex, but we know that underneath each of those 3 areas, there's a lot of work that can be done almost parallel, and informs the work we do. So leaders need to support efforts to educate and train the workforce as appropriate for the role, and we need to provide, resources for that to occur and time off for our clinicians and others in the care setting to have time to really be able to learn about this. Hospitals also can begin by creating and improving policies, signage, de-escalation training, simulation training, among other things. Leaders need to promote a coordinated data collection effort so they can understand the depth and breadth of the problem, as well as for measuring outcomes. We find in our country, and I think probably this might be something similar around the world, that there is no exact definition of violent activity. So we know that in the future, we really need to have common understanding of what the metrics are and what the definitions are. And leaders also need to find ways to keep all levels of the organization accountable and committed to creating safer environments. The last item to consider with this framework is that it encourages leaders to consider how to address both workplace and community violence. Community violence prevention is an entire body of work with many different facets, and we're working to understand how to support our members in assessing and addressing the violence that they experience in their particular communities. And that's why I believe collaborations are so important. And while HAV wasn't created until 2016, our American Organization for Nursing Leadership met with the Emergency Nurses Association in 2014, a few years prior to the actual AHA work, to develop guiding principles on mitigating workplace violence. Both organizations believe that addressing the issue requires a joint commitment and collaboration for leadership and staff, and the next step was to involve healthcare security and safety. We're very glad to have a strong collaborative effort with the IAHSS, which is the International Association for Healthcare Security and Safety. I'll share more about our work together on the next slide. And our next speaker, Paul Sarnes, is president of IHSS, and he will be presenting next virtually, so you'll hear from him as well. AHA has also collaborated with the Joint Commission, an organization that accredits healthcare organizations in the US and also internationally, as they prepare to release new workplace violence standards that will be implemented in January of 2022. Actually, those standards were published in July of this year, and hospitals across our country are, in active preparation to make sure that they are compliant as of January 1. We've also had the pleasure of working with the International Hospital Federation and learning more about the ICRC and the Healthcare in Danger Initiative. And lastly, the Health Alliance for Violence intervention that works with hospitals across the country to implement hospital-based violence intervention programs. So there's lots of organizations that are interested in this very serious problem, and more importantly, we really need to be working together. So that collaboration is so critically important. So the framework that I just discussed was recently released, actually within the past 6 weeks. And I'm happy to share that so far we've already received really great feedback from our member hospitals. We've also released a new guide in collaboration with IAHSS for healthcare and security leaders on how to mitigate violence in the workplace. We are developing a series of case studies that showcase the many safety strategies that have successfully reduced violence in healthcare settings. And next year, actually late this year and early next year, we're updating what was a little bit dated 2014 AONL and Emergency Nurse Association Guiding Principles and Toolkit that I mentioned a little bit earlier. We've already set the stage. We have the groups ready to convene, and we're very anxious to get moving on that work. We have webinars and podcasts planned to continue to explore the challenges and solutions to make healthcare settings safe, both for our healthcare workers, but also for our patients. So an important part of the work that we do is creating awareness through social media called Have Hope Friday. The purpose of this campaign is to raise awareness that violence is a crisis and it disproportionately affects our healthcare workforce. We also want to unify the healthcare field and serve as a vehicle to share the great work happening across the country. It's always the first Friday in June. Save the date, June 3rd, 2022, and you can join us on social media and learn more by using the hashtag HaveHope. And in closing, I just would like to mention our AHA website that has the information that I referenced. To learn more about our efforts, please visit the website. We welcome your comments and feedback. We believe it is an iterative document. Our toolkit, we expect, will grow more robust as we collect more information, and we would really love for you to participate in that. And here's my contact information if there's any questions for me. Thank you.
Thank you, Robin. I think AHA has become really a champion in looking at the issue of violence against healthcare, violence in hospitals. And this framework is absolutely amazing. I really recommend that everyone looks at it in detail. And hopefully we're going to have more hospital organizations interested in expanding, translating, maybe adapting and implementing the framework in different settings. So last but not least at all, we're going to hear from Paul Sarnes, the president of the International Association for Healthcare Security and Safety, and he's going to give us an address talking exactly about resources, available resources for people who are interested in working with the topic.
Hi, my name is Paul Sarnes, and I am the president of the International Association for Healthcare Security and Safety. So who is the International Association for Healthcare Security and Safety? Well, we are the only organization solely dedicated to professionals who are involved in managing and directing security and safety programs in healthcare facilities. We have over 2,300 members from the United States, Canada, Australia, Europe, Asia, and Latin America. And we represent over 850 healthcare facilities throughout the world. Our mission is simple and straightforward: leading excellence in healthcare security, safety, and emergency management. Both the World Health Organization and the World Medical Association have described violence against healthcare workers as a growing epidemic. Our number one goal is to reduce violence in healthcare. We will do this by defining, gathering, and evaluating data, by developing and sharing leading practices, and by collaborating with other like-minded organizations. Our foundation's annual crime survey is the only survey in the world that captures data on violence in healthcare facilities. It can be used as a benchmark to compare healthcare facilities' incidents of workplace violence. There are 5 critical components of a comprehensive workplace violence prevention program, and they include management commitment, worksite analysis, hazard prevention and control, training, and program evaluation. The culture of safety starts at the top of the organization. Senior leadership must be engaged in actively supporting the program. The Joint Commission recently published a new violence prevention standard that we were a part of developing. And this new standard requires leadership oversight, policies and procedures, data collection and analysis, and training of staff. Now, there are multiple ways to conduct a security assessment. You can hire a credentialed security consultant or utilize an internal expert. A credentialed expert will have the designation of being a Certified Healthcare Protection Administrator, or CHPA. The CHPA is designed and administered through IAHSS. You can also take a team approach and use our standards and our guidelines as a benchmark. There are many de-escalation programs that can provide healthcare professionals with the skills to identify and manage aggressive behavior, and healthcare facilities must determine what program would best fit into their culture. Facilities must also determine what employees would receive training and the objectives of the curriculum. Employees could receive different levels of training based on their risk to violence. Reporting systems must be easy to access and must not have barriers to report incidents. All employees must have access to an incident report. The ability to push data or notifications when an incident occurs and the ability to collect data must be considered when choosing to purchase or develop an electronic reporting system. For any program to be successful, it must have the financial support of the organization. Funding through capital, infrastructure, and operating dollars is paramount to the success of a violence prevention program. Violence prevention planning must include the physical location of the healthcare facility, the type of services that are provided, and the type of clientele served. A typical practice is to include a review of the crime rates in a 3 to 5 mile radius of the facility. The political, economic, and cultural conflicts in the region must also be considered when conducting the assessment. Past incidents of aggression, and particularly incidents that occurred that were not followed by significant mitigation strategies, must also be included in the review. Certainly, the COVID pandemic has given our industry the opportunity to review access points and screening of people as they enter our facilities. As a general rule, access points should be limited to make screening and surveillance of people easier to accomplish. Knowing the typical response time of the external agencies who respond to acts of aggression must also be included. The inability for a quick response puts the burden of providing protective services and emergency response services on the shoulders of the facility's employees. We currently offer a workplace violence prevention bundle to help facilities design and manage a comprehensive workplace violence prevention program. The bundle includes specific industry guidelines for violence prevention, as well as our facility security design guidelines. In the near future, we will be offering a workplace violence prevention certificate program. This program will provide leaders with the necessary skills and resources to effectively design and manage a successful program. Our design guidelines are intended to assist security practitioners, design professionals, building owner representatives, and planning leaders in making informed decisions related to the application of proven and effective principles in the new construction and design or renovation projects. The guidelines are designed using the concept of crime prevention through environmental design and cover all areas of the healthcare facility. The guidelines provide generally accepted industry-leading practices to provide a safe and secure environment. These guidelines cover the internal and external environments, inpatient facilities, emergency departments, behavioral health areas, pharmacies, cash collection areas, infant and pediatric facilities, areas with protected health information, long-term care facilities, as well as alternate care sites. Now, this is a rather busy slide, I know, but this is an example of a security vulnerability assessment. The assessment is created by listing all the specific threats that the facility could face, all the risk factors, all the risks that the facility could face based on the risk factors that were described earlier in the presentation. Once the threats are identified, the healthcare facility must then identify the probability that the incident could occur. Looking at the history of prior events, near misses, or incidents that occurred in similar healthcare facilities could help to determine the probability. Healthcare facilities must then determine the impact on people, the facility, and the organization's credibility and brand that fosters community confidence. You can then determine the level of preparedness and vulnerability. The assessment will allow the healthcare facility to develop and prioritize strategies to reduce the overall risk to the organization. This slide demonstrates some of the stakeholders that must be included in the overall assessment and the development of the mitigation plan. Clinicians, security and other internal responders, risk management and legal, behavioral health and social services, human resources, labor unions, external responders, they all have experience in managing risk. IAHSS has many resources to support healthcare facilities to design and manage a successful safety, security, and emergency management program. As mentioned earlier, our industry and design guidelines are a great starting point. We also conduct and publish research projects on current threats and vulnerabilities in our industry. We conduct an annual crime survey that allows facilities to benchmark their data against other facilities. As mentioned earlier, we will be launching our Workplace Violence Prevention Certificate program in the near future. We are also in the design phase of our data warehouse project, and this project will provide facilities with the ability to drill down on data to compare the impact on certain mitigation strategies like arming officers, de-escalation training, non-lethal weapons, canines, and other such programs. We also have many active shared interest groups. We have an active interest group we have a women in security group. We have a long-term care facility group. We have a canine program, and these are very active groups that meet on a monthly basis to share challenges, successes, and best practices with each other. We also offer free monthly webinars to our members. There are other great resources available through many facilities, through the American Hospital Association's Hospital Against Violence Initiative, as well as the International Red Cross and Red Crescent's Healthcare in Danger program. You and we all have the power to reduce violence by sharing the benefits of membership in IAHSS, by using our industry guidelines to design and evaluate your current workplace violence prevention program, as well as your security, safety, and emergency management programs, by ensuring that the violence prevention program leaders attend our upcoming violence prevention certificate program, and by ensuring that our design guidelines are consulted when planning for any renovation and construction project, by sharing all the resources that are available to develop a comprehensive workplace violence prevention program, and by continuing to collaborate to mitigate violence. Let's all keep up this great work and the collaboration moving forward. Please connect with me or IAHSS through LinkedIn, Facebook, Twitter, and Instagram. And please have your security leaders connect with us. And together, we can lead excellence in healthcare security, safety, and emergency management. Thank you.
that the awareness of violence against gender-based violence is not that high. And so sadly, our staff are not recognizing gender-based violence even within the patient population. And I merely mention this as an indication of the challenge and the battle that there is. It's not just about saying, you should report and feel free and feel protected. That's only part of the challenge. The challenge is to say and speak out in support of the patient population and the communities that they're finding. And so I think we have a lot of ground to make up in this space, sadly. Thanks.
Thank you. Robin?
Yes, I would agree. But I also think that, times are changing. And what was acceptable or accepted, I should say, 20 years ago, even 10 years ago, is not okay now. So, I know that there are many organizations that are actually doing training with their own staff, so that they are aware. And I've heard clinicians say, I never realized if I said this, that was the way it was perceived. So I think there's a lot of awareness. And, you mentioned earlier reporting. I mean, making sure that people feel comfortable to bring these issues forward. And it's challenging and difficult, but we need to continue to work on this because as the questions mentioned, this is, a pervasive issue.
Thank you. Paul, would you like to add something to the question?
Yes, just to add that I think we would all agree harassment is a form of violence. And it's really important that is included in the definition of violence for the organization. And that gets leadership right on board. When that is included in the definition of what is not going to be tolerated, it puts the ownership on the leadership to resolve the issue, to take active steps to resolve if it's harassment, if it's violence, whatever it may be. So I think it's really important to include that in the definition. And then as the other speakers have mentioned, making it very easy to report this, that there's no barriers, that there's no retaliation, that it's a very comfortable setting for the employer to bring forth a concern.
Thank you. Yeah, I think we get two takeaways from this question. Very importantly, one is to raise awareness. I think you all mentioned that. And second is to create some protective environment for reporting to happen, right? It's not just the idea of saying there is an open system to report, but also being very clear and transparent about what is expected of someone who's reporting, what kind of protection will be granted to that person once the person reports, how the report will be treated itself, right? So that we make sure that this is not something that is going to end up in the hands of someone else in an inadequate moment or in an inadequate way. Yeah, thank you. Any other questions? I don't know how to update here from the Q&A. Okay. But if in the room someone wants to ask a question, yes, please. We have two people here.
Thank you. Thank you
Bettina.
for all the presentations. My name is Bettina Borisch. I'm the CEO of the World Federation of Public Health Associations. And my question is as follows. We do see an increase in violence against everything that is considered official representative of state, like policemen, like other offices. Could you, in your place in South Africa or also the International Association, make correlations with the development of aggression against healthcare professionals and aggression against, let's say, other representatives of those above?
Okay, so Dr. De Vries, you want to start again? I think this has a lot to do also with your role.
Yeah, thanks. I think that's a great question. So, one of the things mentioned really early on in our engagement with staff relates to, shall we say, the markings around the ambulance. Anything seen to be partisan or politically aligned was an issue that they felt quite strongly about, because of this association. I mean, we're a public sector EMS, so it's ironic that they would flag the need to be not linked to the state. But I think what they were trying to convey is the need to be linked to parts of the state that are polarizing, either politically or based on your views. What also to add to that is one of the concerns have been, particularly in linking with the police, is that we become collateral damage within skirmishes with the police. And there have been occasions where we were attacked because they were attacked, not because they came after us. And that has been a concern in some instances. And we've had to work really hard in building that relationship with our law enforcement. But I guess to answer it, it's why we invest heavily in a community engagement strategy. I see it in Paul and Robin's pillars, and I couldn't agree with it more. I think we because of this link to the state, because of the lack in our country, lack of service delivery on the part of the state in some areas, we've had to show our community that we want to address that. We have to show that we have links and we are part of them, not merely a disarticulated aspect of the state. So I think it's a really great question. And I think it also speaks to the issue around amnesty and signs that link to amnesty. I think the ICRC is a perfect example of the need to show nonpartisan through an emblem, through a symbol. And I still believe that that's probably where we should be investing rather than linking with organs of state in that way. And I think EMS services would go a long way to find a more, shall we say, non-partisan, non-polarizing way of resembling these services. But a great question, thanks.
Thank you, Dr. De Vries. Paul, I know that the IHSS does work to better coordinate with law enforcement, so it would be great to hear your take on this, because I think that Dr. De Vries just mentioned that yes, there might be some negative associations, but then what's your solution to that? I know that you have some ideas.
Yes, thank you. That is a great question. Certainly the partnership with law enforcement and any first responders is critical. There has to be a relationship prior to a call for help. There has to be the ability for them to recognize what they're entering. That's the facility layout itself, but also the fact that they could be dealing with somebody who's having a psychiatric emergency, somebody who's under pain. And when law enforcement is typically responding, they're going there because they believe there's a criminal intervention or there's a police or law enforcement intervention based on a criminal event. So we have to train, we have to do joint exercises with the police. They have to understand the type of clientele we serve, the services we provide, so that they have a true understanding of what the challenges may be when they enter our facilities. You know, with the political unrest and the civil unrest that many countries have gone through, it's really important that the healthcare community and the law enforcement or the enforcers or the responders are on the same sheet of music, and that they have the same mission, and that's to provide great care and compassion to the people that we're serving. When there's a conflict in that mission, that's where issues tend to erupt. So we have to make sure that we are out there leading the forefront, training, educating, and making sure that they're aware of what they're going to walk into when they enter our facilities.
That's a great point. Thank you, Paul. And indeed, I think there's a lot that one can learn from the other. Health workers can learn from law enforcement can learn from health workers, so that they have complementary and not obstructing and not conflicting missions, right? I would love to hear from Robin how that fits into the framework that the IAJ develops, the whole dialogue with community members, with other partners.
Well, and I think you said it, Anna. I mean, it's very hard to separate community violence from what we're experiencing in our, in our healthcare settings. So I think it's, again, to Bettina's point, I mean, it's just, we have to be aware and prepared for what the community is experiencing. And, the hospitals and healthcare organizations, I mean, we all have a responsibility to our healthcare workers and to our patients. We safety is, like the most basic need and requirement that we have to provide for both the staff and our clinic and our patients. So all those things that we talked about in the framework, education, resources, leadership commitment, creating that culture is ongoing work. It's not going to be a program that it's one and done, and we've done our annual education and we don't have to worry about this till next year. It is constant vigilance, working with law enforcement, working with our security professionals. We all have to be, as Paul said, on the same sheet of music. Totally agree.
That's great, thank you. We had another question from Otmar. Yes?
Thank you very much. Otmar Klaube, World Medical Association. I have two questions. The first one relates to what we have just discussed. That is, are there good models in changing the legal basis for protecting health personnel that is going out or even in hospitals? I know that there are some examples, but I wonder whether there's already some experience and there are some recommendations to that, because that is a question whether we should actively advocate for that doing this, or whether you would say, well, that's rather not helpful at all to have it. And number two is an observation which I have made in my work with our member associations over the past decade, or actually a little bit longer, because the international occurrence of reports on violence, and I'm not speaking about now violence in wartime, in armed conflict situations. I'm speaking about civil situations. The reports were increasing, and my question to my members was, well, is that something you are observing as well? And the common answer was, for nearly all of them, no, only exceptional cases, until finally over the past years they learned that it was a series of exceptional cases, and that it was more a common pattern, that there was an increase in violence in that. And that goes together with another observation I have made from some of the early reports of that, which saw that even, and now I speak for physicians, but I'm sure it's not very much different for nurses, that physicians who were victims of violence very often reflected this as something they would be themselves the cause of that. Although from an objective perspective you would say, well, certainly not, you have nothing to do with that, and by the way, any aggressive or even violent behavior is not acceptable, period. Regardless how you have behaved professionally or not professionally, except you started the violence himself. But very often they would think themselves, well, it may be my fault, and I have not performed well enough, and therefore they were not reporting and not giving the blame to others because they themselves would be cause of that. Is that something that you also have observed? Is that something that has been reflected in your work as well? Thank you.
Thank you, Otmar. That's a long two-fold question. So let's start with this. I think this last part is extremely interesting to hear back from you. So what's the experience that you hear from, the frontline colleagues, from the practitioners, the health colleagues who are exposed to the realities? How do they position themselves in face of that, and how they come back to you and tell you, yeah, I think that I should be reporting. This is a problem. This is not a problem. Robin, you want to start?
Okay, I'll start. Before I was, working for the AHA, I was a chief nursing officer in New Jersey for 20 plus years and spent the bulk of my career as a nursing leader. So I have a lot of experience, on the ground, if you will, leading the charge in New Jersey. So I would tell you that, first of all, there's a level of issues and concerns that I would characterize as violent, incidents that were just sort of accepted in the norm. And it was low level, if we're going to look at it from the spectrum. It was maybe incivility. It was what I would characterize as disrespect. And many times when patients didn't have capacity. So our little elderly patients that were demented, that were combative, things like that, nurses just felt like that was part of the job. And, okay, we would have patients like this, and, we would have our strategies for dealing with these patients, but it didn't rise to the awareness of this is a violent act, or this is something that we should report. In contrast, we had some patients come in that would be extremely violent. So, I think we employed different strategies. Those patients we maybe tended to, quote unquote, write up the incident report for, but I don't think we had an understanding of the whole spectrum of what would be an incident, a violent incident, probably even a decade ago. I have had conversations with some of my former nurses about, their reaction, and as you said earlier, what could I have done differently? And, maybe a lab report took too long and I didn't get back to that patient, and, whatever the situation may be, and they did blame themselves. So I do think that's an area that, we do really have to delve into. But I think the more that we're educating our staff about what is not okay, regardless of intent of the patient or family, whether it was an accidental, elbow in your in your jaw because, the patient was, lacked capacity and had dementia, for example, it's still, an act of violence towards the person, regardless of the intent. So I think we do have a lot to do in processing with staff, physicians, nurses, everyone who's experienced, violence firsthand. And we need to do a lot more of discussion and education with them. I have lost staff who've left the profession because of incidents that have happened. And one was a brand new 4-month nurse who had an amazing future in front of her. She was a stellar new graduate nurse who was so excited and, really just so so full of dedication. She had a significant incident. She was injured, went home and physically was fine, came back to work. We intervened all we could, and 4 months later, she just said, I just can't do this anymore. And I think about her to this day because and she left the profession entirely. And we can't afford to lose even one great nurse. And it's not about it being a nurse. It's one person that is a healthcare worker that is it's one too many. And I'm afraid that with the greater incidence of violence that we have been seeing across the world, obviously from, the statistics that we learn about and that we see, that, this is just, it can't be considered an occupational hazard, or you just have to put up with it. It's not okay. So we've got a lot of work to do.
It's indeed not okay. Dr. De Vries, do you have a similar experience in your service?
Yeah, thanks, Anna. I think Robin answered that really well. I maybe not to add to that, but maybe the first part of the conversation around the legal response. I think on the back of what Robin said, that we have to find some way to emphasize the importance and how crucial this is. My view is it's the idea of numbers is not conveying that. This is a threat to the stability of the state. And that's healthcare is a basic human right. And so the moment professionals or health practitioners start wondering whether they should come to work today, I think we are risking far too much. I think we are probably in South Africa not as progressive as in other parts of the world in terms of legislatively protecting the health worker. I would say that it's not so much about what the legislation does, but what it represents. And I think that message needs to go out, because if we are all, and we all are, myself included, dependent on someone's decision to come to work, my safety is dependent. My well-being is dependent on their individual decision to come to work. We have to protect that decision. We have to support that decision. And I think one of the ways to do that, the easiest ways to do that, is legal, with legislative tools. So I don't think anywhere near enough is being done around that. Thanks.
Thank you. Paul, would you like to add something to that reflection?
Yes, absolutely. If any of us were walking down the street and we were assaulted, we would get the law enforcement community involved. We would report that. We would not tolerate that. Unfortunately, in many parts of the country, and even different states throughout the United States, there's different laws. Some laws protect all healthcare workers, where other laws only protect licensed healthcare workers. So if a physician is assaulted or a nurse is assaulted, it's a higher degree of a crime. But if a security officer or somebody that's unlicensed is assaulted, it's a simple assault. So I think we all have to continue to work with our legislation, with our political bodies to make sure that all of our healthcare workers are protected. Once that happens and the laws are set in stone and they're consistent, then we have to encourage our employees to get involved in the criminal justice system. If we don't do that, it's almost like tolerating the act itself. We won't tolerate it if it happened outside the four walls of our facilities. We should not tolerate it when it happens inside.
Thank you. I wanted to take 2 minutes also to react, I think, to this discussion right now, because I think there are some very, very important points. One of it being what Robin put forward, the fact that normalization of violence is something that we also have to fight back. We have to do it from education of health workers to the moments that we're with them in a healthcare facility. We have to be supportive. We have to constantly make people aware that violence is not something to be happening, is not something that should be taken up as routine, as something acceptable, right? And the second point that I wanted to highlight is then bringing it back to these legislative measures that we can put in place. I think there is a degree, a very important degree, to which we do have to respond. That is the state level or the, let's say, the official legislative level of a country or a body. But I think also at the facilities, there is a degree of autonomy and a degree of work to be done in terms of putting in place very straightforward policies that might be more protective to health workers, and they are not necessarily conflicting to any other legislation existing outside. For example, putting in place no weapons policies in healthcare facilities is something that is relatively easy to do. It's not something that, for a hospital setting, for example, demands a 10-year advocacy with the state representatives to put in place an official legislation. It's something that can be put forward by a service directly, and that can be managed directly by the service, and that will immediately reduce exposure of the workers and the patients in that healthcare facility to the circulation of weapons, for example. So I think there are several degrees to which we can act, and I think the discussion today really touched upon these different degrees, from the systemic level that Dr. De Vries presented, from a governorate looking at emergency service, dialoguing with law enforcement and all, to what Paul told us about training staff towards the specific skills and measures that you have to put in place, and the AAJ very, very complex and comprehensive framework of looking into education, for example, and raising awareness, collecting data, connecting to others. I think we're looking at really a very broad set of opportunities, actually, for us to be acting in our workplaces and within our communities, our networks, to make sure that we are addressing the problem, that we're not forgetting it, that we're not closing our eyes to this reality. So right now I wanted just to give back the floor to the panelists, just so they can have 1 minute of closing words before we finish the session. So Robin, I'm going to start with you.
Okay. I don't think I need a whole minute. I think I've said everything I wanted to say today. Really appreciate your attention. This is a problem and an issue, obviously, globally, and we just need to continue to work on it, and we have a lot of work to do.
Thank you, Robin. We do, but we're on it. Dr. De Vries, please.
Thanks very much, Anna. And thanks again, just for the opportunity to the platform. I think for us, I personally, for me, it comes around this, decision to come to work. I'm every day I'm grateful that sufficient staff in my organization, with 2,000 people strong. So I'm really grateful that they've made the decision to come to work. And I think we don't hero or amplify or acknowledge that decision, and not just for EMS or nurses or doctors, but police officers and firemen, and as Paul mentioned, even security guards and cleaners who keep our facilities going. So I do think that this decision to come to work needs to be prioritized. It needs to be protected, and I think we need to do a lot more to make sure that we keep making that decision, because we all are severely dependent upon it. And thanks for the opportunity.
Thank you. Paul?
Thank you for this wonderful opportunity to collaborate. If you think about what we do in healthcare, it's meaningful, it's purposeful, we're changing people's lives, we're healing. This is a pandemic in itself. This is a worldwide pandemic. We have to continue to collaborate like we are today to make a change. So we are excited to continue to collaborate with all of our great partners.
Thank you. So I would like to thank you all for listening today. Also, once again, thank you for the International Hospital Federation for the space of debating this. And hopefully, we're going to connect further in different channels to continue discussing and addressing the issue wherever we work. Thank you.
Thank you.